Okay, so good afternoon, everyone. My name is Dr. Shemer from Shemer Medical Center, Israel. I hope that everyone can hear me well. First of all, I would like to thank the organizing committee for inviting me to speak here today. And in the next couple of minutes, I will present the many phases of the Pachychoroid disorder. So we'll begin with a case presentation. We go back to December 2007, when a 51-year-old male arrived into our medical center ophthalmology unit. He was referred due to a retinal lesion in his right eye, accompanied with a reduced visual acuity. His past medical history includes ischemic heart disease, hypertension, and type 2 diabetes mellitus. He has no ocular background. His visual acuity was 6/12 in his right eye and 6/6 in his left eye. An anterior segment examination was unremarkable in both eyes. A posterior pole examination revealed a round macular lesion with retinal pigmented epithelium changes mainly in the margins and a yellow-gray elevation located between the optic disc and the fovea. On the right side here, we can see a red-free image demonstrating a hypopigmented lesion. The posterior segment of the left eye was unremarkable. Here are some images taken from a fluorescein angiography in the right eye of our patient. At the end of the atriovenous phase, we can observe a round, central, and well-marked hyperfluorescent staining. In addition, a peripheral pooling is noted, which is progressively enhanced in terms of power rather than size and remain unchanged until the late phase. These findings suggest a subretinal fluid accumulation. In the left eye, RPE changes as well as hypo and hyperfluorescence changes are observed. This is a time-domain optical coherence tomography. Here we can see a vertical and horizontal scans through the fovea. We can clearly observe the loss of foveal depression, intraretinal fluid accumulation, and a massive pigmented epithelium detachment with RPE atrophy and decreased reflectivity of the choroid layer. Here are the wavy RPE of the left eye. So according to the presented information, we conclude this patient had a chronic multifocal atypical central serous chorioretinopathy, or CSR, or as I will refer to in this presentation, CSCR. Before we dive into the world of the Pachychoroid spectrum disease, first we must understand and define the normal choroid anatomical characteristics. Basically, the choroid is comprised from 3 vascular layers. Going from inner to outer, first is the choriocapillaries, then the medium-sized blood vessels named the sapphire layer, and finally the Haller's layer, which consists of large vessels. Pachychoroid disease is defined by focal or diffuse increase in the choroidal thickness. The definition actually consists of 2 characteristics. The first is the dilated choroidal vessels in Haller layer, pachyvessels. The second one is thinning of the choriocapillaries and Sattler's layer, with or without RPE abnormalities. The etiology is not fully understood, but most hypotheses think that thick choroid with dilated or hyperpermeable vessels lead to focal Brook membrane and RPE disruption that leads to serous retinal detachment. There are multiple risk factors such as type A personality, emotional stress, pregnancy, tobacco disorders, and drugs. And there are several clinical manifestations that have been described to reside within the Pachychoroid spectrum disease. So this is actually a spectrum of several diseases as we now understand it. So first, the central serous chorioretinopathy, the CSCR, is the most common manifestation that is characterized by subretinal fluid, PEDs, and cystic intraretinal fluid. Then the pachychoroid pigmented epitheliopathy, PPE, is characterized with irregular elevation of the RPE, as we can see right here, with or without elevation of the choroid. Next, the pachychoroid neovasculopathy is described by this double layer sign between the Brook and the RPE. Then the polypoidal choroidal vasculopathy or aneurysmal type 1. It is characterized by irregular PED elevation, or actually aneurysm, as we can see in this image. And less and even more uncommon are the two last subset of diseases, which are the focal choroidal excavation and the peripapillary pachychoroid syndrome, which will be presented later on in this session by my colleague. And now we go back to our patient. So the patient was treated with 5 cycles of anti-VEGF, anti-vitreous, yet his visual acuity did not improve. And then he was lost to follow-up. 6 years later, the patient came back to our clinic. An OCT of his right eye shows again a large PED, and on his left eye, there are now several PEDs. The next visit was again in 4 years, at 2018. We can see here an OCT with enhanced depth imaging describing a thickened choroid from the right, as well as in the left with small PEDs. In fundus autofluorescence imaging, we can observe the RPE atrophy and even the gathering in the right eye. Both eyes are demonstrating hypo and autofluorescent areas. So if we want to sum up, until now, we've seen a patient with atypical CSCR in his right eye and a thick choroid and RPE changes on his left eye. Then the patient is presenting with complaint of shadowing in his lower visual fields in January 2019. A large upper subretinal hemorrhages are detected in 2 spots. We did not observe a CNV, yet we can suspect a progression to PCV or PNV. 2 days later, the hemorrhage is now directed toward the macula. It was then decided to proceed with surgical intervention. So prior to a pars plana vitrectomy, the patient undergoes a single anti-VEGF antivirus injection. Then a core vitrectomy was performed. We induced a PVD with a triescence, as seen in this video. Then a retinotomy was performed with diatrophy, and TPA was injected. Finally, fluid air exchange was done. Following the surgery, the patient was instructed to lay in the face-down position. Here we can see, Here we can see the changes in the colloid fundus images as well as in the OCT slide with fully resolved hemorrhage and PED in his right eye. And 1 year later, in June 2020, the right eye was stable. However, the left eye, we can definitely see an increase in the PED. So if I want to conclude, our patient first presented with PPE, then with CSCR in his right eye. But finally, his right eye progressed to pachychoroid neovasculopathy, PNV, and polypoidal choroidal vasculopathy. And his left eye is now starting to progress as well with PPE. And that's all for now. Thank you very much for your attention.